Hello and welcome to the Public Health Spotlight podcast, brought to you by Panoramic Associates and partnered with the ADPH. Personally, I'm very excited to be hosting this podcast today. From someone who's been born in this city and has lived here my whole life, I'm excited to introduce the Director of Communities and Public Health, Christina Gray. Welcome to the podcast.
Thank you, Callum.
Thank you for joining. I am extremely excited. I've got a very Bristolian accent.
I think you epitomise the city.
Oh,
You do.
I'll take that as a
The passion, sense of place,
best podcast.
pride in place.
Thank you. We will jump straight in. So public health, starting as early as you can remember, what got you into public health in the first place?
Well, I think for me, as for many people who end up in public health, it's a natural progression of values, early experiences, interests. So for me, very early, I was interested in social justice, social action. That took me into an interest in academically, social policy, the social sciences. And inevitably, those questions, those big picture questions, take you to a public health perspective or a population health perspective.
With that in mind, what got you so deeply interested in like the social side of it? And like you said, it's from when you began, it was that straight away. You had the big questions. Except, was there anything early in your career that sparked that interest? Upbringing?
Yes, and I think many people, for many people, their values, their outlook, the things that matter to them are shaped from early experiences, family experiences. I'm a Scot, can't hear it now, but I am a Scot. And growing up in Scotland, strong sense of public service, a strong sense of justice, of fairness, of wanting to do well, of aspiration, but actually recognising that it isn't an equal playing field and that society needs to look after and be fair and create a level playing field. So I think Scotland, certainly when I was growing up and the experiences that I were exposed to, was very much about public service and social contract.
Amazing. And just took you into your career, which is nice. So just for anyone who doesn't know, could you just talk us through your career, high level, and don't have to go into too much depth because we'll cover it later on.
Of course. So as I said, sort of natural progression. I started off working in very grassroots roles in homelessness services, youth justice. Spent some time in Northern Ireland, which at that time was at the height of the Troubles. Strong links between Northern Ireland and Scotland, which is why I ended up there. And through that, undertook an initial professional training in social work. That training in those days was rather different to social work training now, I think. And it was very much a training from a social justice lens. So we were asked quite probing questions about the nature of social work, the nature of the wider determinants of health, and I was introduced to sciences such as epidemiology. So it was quite a natural progression from that into public health. As soon as you start looking at social justice and the conditions, the differential conditions that some individuals or communities experience, you start to get into the public health disciplines of what are the drivers of this, what are the conditions, how are we creating the conditions that result in such inequity. And health inequity is simply the result of inequality. It's an outcome of structural inequality.
And then from then into the career, what else did you do?
So the route from my community activism and social work was into a community health development role.
Yeah.
Things changed at around that time. The primary care trusts were created, And around that time, public health specialty roles and training and accreditation was opened up to disciplines other than medicine. So public health, or the public's health, and the need to address it has been with us forever. And of course, at the end of the last century, it was the sanitary engineers that were doing all the public health work. With the advent of vaccination programs, became more of a medical discipline and had been for many, many years. But of course, as we're moving now into more chronic conditions, more social impact of disease, other disciplines are important, not just medicine. Medicine, absolutely an important part of public health, but also the disciplines of housing, of social sciences, nursing, teaching, education, whole range of planning, planning and place-based disciplines. So all of those come together in a core set of knowledge and skills, depending from your discipline. So I was fortunate that at that time the career pathway to specialty registration was opening up, and I was able to take advantage of that. Obtained my specialist registration, and then that was when then I took a role as I was an associate director around that time. Took a role as a consultant, and subsequently the role as director here.
Lovely. Thank you. On reflection, looking back in your career as a consultant and as a DPH, what were the most pivotal programs or projects of work that really sort of stay with you? What were the challenges initially? What did you implement, and what were the outcomes that you saw?
So I wouldn't limit the most profound experiences or my biggest involvement in public health, sorry, got a bit of a cough, as being necessarily when I was in those roles. Those roles enable you to operate and deliver programs and outcomes and make impact from a particular perspective. But I would say all of the career that I've just, the experiences that I've described, working directly with homeless people, living and working with homeless people, has certainly had the biggest impact on me. Living and working in Northern Ireland and understanding, or getting some insight at least, into the sort of visceral conflicts and passions and differences that divide communities. And then working in the primary care trust, leading on with others on the race and health programme, where I was working with a fantastic group of colleagues with national programmes, the National Race for Health programme. We had a Bristol Race Equality and Health programme. My friend and colleague Tara Mystery had been leading on that for many, many years. Race equality and mental health. All of those experiences and programmes add up to a whole, so that now one of the things that I'm most proud of that we are doing today in Bristol is that we have got a race and health equity programme, which reconvened in COVID, is led predominantly by phenomenal Black professionals, supported by those of us who can help address barriers and blockers in the system. And that programme is influencing the way that the Integrated Care Board is thinking and working. We've got engagement from the hospital trust, 28,000 people employed in our hospital trust, many of whom from Black and minoritised communities, and a huge employer in the city. So it's not one thing, and I think that's also sums up public health. Public health is the long game. It happens over many, many, many years, and it happens through with many people and alliances. It's never one thing. It's never you. You play a part. You take opportunities. You play your role at wherever you are in the system at the time.
Love it.
But it's not to do with the title. No,
So that's how. No, it sounds like early in the career when you've really got your sort of like you're in with the community, like the role. it seems like that obviously like shapes your perspective. Any other examples? Like you mentioned a couple there, but just around like the actual challenge, what you implemented, the outcomes that you were part of, not necessarily to do with the job title. But
Yes. So an interesting program that we've been working on in Bristol recently is our Health at Night program. So Bristol's a core city. We have a big nighttime economy, so entertainment and leisure economy. And during COVID, I was introduced to people who were working at night and the challenges that they faced, the challenges through COVID and the subsequent challenges since. So I did one of my Director of Public Health reports a couple of years ago on the city at night. And that was fascinating. What then opened up was, of course, we have a big entertainment industry. We're a destination city, so every evening, and particularly at weekends, hundreds of thousands of people come to Bristol for events. And yeah, I can see Callum. You know this. We're a festival city above anything else. So many people come and go. But in addition to that, we have everybody who works in health and care. All of those hospitals are 24/7. All of the Amazon deliveries that you get, big warehouses on the edge of the city in Avonmouth, where people are working 24/7 to get those parcels out to your door. We wake up in the morning and our shelves are stacked in our supermarket. So what my report highlighted to us, and that the city was interested in, our committee was very interested in, was the inequalities that are experienced by those people who are working at night. If you're working at night, your family life and leisure is disrupted. You're likely to be in lower pay, insecure employment. Your circadian rhythms are disrupted, so mental health and well-being is disrupted, and there aren't the services. You have high levels of smoking and drinking in some of the industries because that's what happens. And even when we looked at what was happening in our hospitals, those who are working in hospitals or health and care, they couldn't get access to healthy food, for example, at night. So people are snacking. So that report was very illuminative to me, and was taken up by a number of our partners, health and wellbeing board partners, and the hospitals themselves had a look at what they were providing for their night staff. So that, I think, is something that was a bit different.
yeah,
I think it was a first. And it's ongoing work. So we have all the work around Bristol rules. You may have seen those if you're out and about on the harbour side or city. The Bristol rules were developed with and by people working and using the nighttime leisure economy to keep people safe. So safety around water, safety around drugs and alcohol, safety around personal safety, violence, travelling alone, safety of women and girls, all of those things. And the Bristol rules have been very, very well received. Taxi drivers trained in safeguarding, looking after those at night. We've trained people working in the leisure industry in mental health awareness, both for themselves and for their clients, drug and alcohol awareness. So really working with a population that is out between the hours of 6 and 6.
yeah.
Yeah.
How do you measure the progress of that? Because that's very interesting. We've never spoken to another DPH that has uncovered that in their city. How do you measure it, considering there's no previous experience of maybe dealing with it before?
Yes. So I'd say two things about measurement. We have a lot of data about what's not working and what can work. So we don't have to, in my view, reinvent the wheel. If we know there's an evidence-based practice, we can put that evidence-based practice into, we should be rolling it out. And we should, of course, be monitoring that locally. But we don't have to start from scratch. With something like the nighttime economy, the first evidence emerged through knowing our population, hearing, listening, lived experience. And we can also look at the data that's in our joint strategic needs assessment, which tells us about incidents for harms at night, violence, substance use, etc. So we have the data and we can listen to voices and we can look at evidence. In terms of what you then do, what interventions you put in place, that has to be co-created with the people who are in that industry. Yeah?
Yeah.
And at night, we can see there are many different industries. So with the certainly the leisure industry, we have done a big piece of work around Thrive at Night, and that is being evaluated by properly evaluated by one of our that's being evaluated by one of our academic partners, a series of academic partners, and will be published. Yeah.
Nice. Thank you.
But we can also continue to look at, are we seeing incidents? Are we responding to incidents? What inequalities are we seeing? And that tells us broadly whether the direction of travel and the interventions we are making are in the right direction. But of course, when you're talking about something that's in a social context, it's not linear.
Yes.
Yeah, you can't say I've done this intervention and suddenly happens, because you've got lots of other things that rightly are happening in and around that.
Definitely.
Yeah.
That moves me quite nicely onto Bristol in general. What is the current landscape specifically in public health in Bristol? What you're experiencing, what you've seen?
Yeah. So Bristol's a core city, as I said, just under 500,000 people and growing. We're a young city, so compared to national average, we've got more younger people. Our younger population are more diverse, so we're a diverse city, but our younger population are more diverse than older groups. We're a city of great wealth. We have 2 universities. Many people choose to stay here. I think we have more second degrees than almost any other city in Europe, I think. At the same time, we have huge inequality gaps. And those inequality gaps are geographically located and embedded into the city. So the public health challenge, and the challenge actually for the city and for the council, is to address those structural inequalities. So the inequalities that we see in health and care or from health are a result of wider poverty, lack of opportunity, lack of being seen, not having access to careers, opportunities, jobs. And so that is the challenge. That's the public health challenge for Bristol. It's the challenge for the council, and it's the challenge for the city.
What are you focusing on amongst all of that?
So there are a number of core public health programs that we have to deliver. We have to deliver our sexual health services, our public health nursing services, so that's health visitors in previous terminology, and smoking services, drugs and alcohol services, domestic abuse services. So the first thing is we have to do the basics right, and we have to ensure that those public health programs are producing the outcomes and running as efficiently as they possibly can. Over and above that, the reason that public health was moved from the NHS into local authorities is that local authorities are the conveners, they are the shapers of place, not on their own, but they are the leader, the convener of that. And therefore, the other big task that we have is to work with all our colleagues right across the council to ensure that we are supporting the council and our wider partners to create the conditions for well-being for health. And all of this is embedded in the council's corporate plan. An ambition to be one council with many communities, so addressing the diversity and addressing prevention. And to address prevention, you have to address inequality. But the levers for that are not always with public health, and then they're not always in the obvious places. They sit with the big regeneration programs. So you may be aware, Callum, we've got a big regeneration program coming in, Hartcliffe, which is one of our most challenged areas. So lots of additional money coming in to work with local people to look at infrastructure, employment, education, housing. And at the same time, Hartcliffe is going to be at the heart of one of the new neighbourhood health pilots for Bristol. So we're developing neighbourhood health approaches through the Health and Wellbeing Board across the city. Hartcliffe is the first pilot. So work there, but the neighbourhood health pilot can't do it on its own. The work around employment, education, transport has to happen in order to create the conditions for people to thrive.
Right.
And that has to be co-created with the people who live there and who experience it. They have to lead it. They are the experts, not our planners or housing people or whatever.
And is that incorporated in the one partnership?
One City Partnership.
One City Partnership.
And yes, the One City Partnership is not a city council initiative.
Okay.
Yeah, the One City Partnership is a coalition of all big organisations, big and small organisations in the city who want to come together to make sure the city is as good a place as it can be. So the council is one partner, an important partner in that process. But in that partnership, we have got the universities, the two universities, the college, we've got schools, we've got youth and community organisations, we've got grassroots community organisations, we have got the community and voluntary sector leaders, we've got registered social landlords, we've got those who are working on environment and place. And what that space, the One City space does, it allows a place for creative conversations where we can become more than the sum of our parts.
Yeah.
Yeah. So we can discuss an issue and everybody can say, I can offer to do this. So we talk about offers and asks. So people will say, I'll offer. This is my offer to this challenge. But here's my ask. My ask to all of you is I need help in order to do something else. So some quite concrete examples that have come out of that are that the city has had a high priority on violence against women and girls and domestic abuse for many, many years. One of the issues that came out of that work specifically were education and employment opportunities for women and others, men and others, who have experienced domestic violence. Now, the levers and the tools for that don't sit with the people who are experts in domestic violence. And they don't sit with us in the Health and Wellbeing Board, who know that this is a high priority issue. They actually sit with the Economy Board. So it was that work programme was led through One City by the Economy Board, and it was one of our university colleagues who sponsored the work in order to create pathways for education, training and employment for women who have experienced domestic violence. And that is really addressing some of the structural inequalities and the opportunities out of oppression. Another example is we have joint board sessions. So the Health and Wellbeing Board, of which I'm a part, had a joint board with the Culture Board. So we have an Arts and Culture Board. The Arts and Culture Board are all the people who are involved in arts in the city. Now, Bristol's an absolute, we are a city of art and culture, of creativity. And on that board, we have everybody from the big arts programmes, the Beacon Centre, the Old Vic, that end of things, right down to grassroots community art and graffiti art. Yeah? So all of it. And we're talking about visual arts, theatre, dance, all types of art. So we had a workshop. The workshop was hosted by one of our arts organisations, St George's Trust, just up the hill there. And it created a space in the room where the opportunities for health and well-being through everything that we're doing through the arts became visible and we could make connections. Now, some of that was about social prescribing through the arts. So somebody who would benefit from a social prescription for their well-being at an individual level into different sorts of art. The rest of it was what those who are privileged know is that art and culture are important. Yeah.
Yeah.
The arts are sponsored by people who have privilege. And it is well known that adds value. Our job is to make sure in the city that is spread evenly, that there is equal access. So what St George's were doing was linking with community groups and making sure that those community groups had free access to their events. The Beacon, which is the new big sort of performance space in the city, is absolutely linked in with schools. It's linked in with community groups. They do have commercial performances and fantastic, big names there, but they also are working very locally and providing employment opportunities, providing training opportunities. They do bursaries. The Old Vic, which is our proper theatre, proper theatre. Big names there, have trod the boards there. They have an inclusion policy where they work with community arts groups to get different groups into that space. Our museum and art galleries, I don't know if you know, but our museums do silent discos at night.
Do they?
Silent discos in the museum. Absolutely incredible. Absolutely incredible. And of course, the M Shed, which is the Bristol Museum, which tells the story of the city, so that people from all over the city can go into the M Shed and they will see their area, their grandfather, their story reflected back. LGBT stories, COVID stories, the Colson statue story. It's fantastic. So all of those things happen because we have a one city approach and we're able to make those connections, which are often synergy, actually, rather than a deliberate planned programme.
Thank you. Is there any other aspects of Bristol you'd like to mention?
Yes, I think there's Bristol has core city status, as I mentioned, and what that does is it provides the city and all of us in the city with different opportunities and different platforms. So we're part of the Core Cities group, and the Core Cities group means that officers and elected members across the council get together with other core cities to share and to come up with common challenges and solutions. We're an international city, so we lead not just nationally, but on the global stage. Internationally, huge interest in our one city approach, huge interest in our harm reduction approach to drugs and alcohol, huge interest in our creative industries sector, and that's international. And we do influence internationally in many ways. Our current leader and administration are involved in that, and our previous mayor is still involved in the Mayor's Migration Council, influencing on the global stage around migration issues, Lord Use.
Thank you. Moving away from Bristol and talking about you, obviously being the DPH for Bristol for 7 years, and I think we spoke previously, like before, it's a very interesting role, but very high reward but high challenge.
Yes.
Right. Going into the role, what or who shaped your leadership style, and what would you say your leadership style is?
Yes, thank you. I think there are a lot of people to mention. So first of all, I really, I have to apologise to anybody whose name I don't mention, because many people have influenced me, inspired me, and continue to do so. But I'll take three different type groups. First of all, from Primary Care Trust days, I worked with a colleague, Tara Mystery. Tara Mystery's just written her book, the book of her story, which I didn't know until very recently. The full, I knew bits of Tara's story, but Tara was chair of the Primary Care Trust. She is Asian heritage. Her family had migrated from India some years ago to Leicester, and Tara had, as a woman, worked hard to obtain her professional identity and shape her politics. And she has worked in social care for many years. And she was the lead for health equity at the time. And I worked with Tara on the Bristol Race Equality Programme, the National Race for Health Programme, and the Bristol Race and Mental Health Programme. Tara's journey, her leadership, her determination, her overcoming of adversity is just truly inspirational. I do recommend her book. And at the same time, I was working with Marvin Rees, who at that time was in my team. And Marvin's, again, the story of how Marvin has overcome his own adversity, come into his own leadership, how he worked with communities and enabled them to link to power. And subsequently, Marvin became mayor of the city here, which was quite remarkable, and he's now a lord. And so Marvin's story, and this is a non-political statement, I have to say, Marvin's story and his journey has influenced not just me, but many people. And I know that he and Asher Craig's leadership during that time, as during the mayoral time, was really inspiring to many of our Black and minoritized communities who could then see that leadership was possible, not necessarily in that party, possibly in other parties, but that leadership was possible. The other group I want to mention are a couple of directors of public health, Dr. Hugh Annette, that I worked with in the PCT, and Hugh had an international career before coming in to a public health role in the UK. And Hugh's ability to synthesize, to lead with the quiet authority, to enable us all to do our job was absolutely, and remains for me. You know, I hold myself against Hugh's standards in this role, and he did the role for 7 years as a joint director across health and social care. Massive inspiration to me. Trudy Grant, that I worked with, I was one of Trudy's consultants in Somerset, and Trudy was a phenomenal leader in Somerset. Born and bred in Somerset, knew her people and place inside out, ferociously competent and focused on enabling public health to have an influence and to lead across her city and her county, her county, and her preparedness in terms of health protection, her requirements, her standards for her consultants really stood me in good stead. And finally, I want to mention 2 people who represent a whole group, or 3 people actually, who represent a whole group of people who have led community organisations. So Aileen Edwards, who's the Chief Executive of Second Step, Jean Smith, who's the Chief Executive of Nalari, and Heather Williams, who's the Chief Executive of Knoll West Health Park. Those 3 women were here when at the dawn of time, really, when I started being involved in public health in Bristol. I went away for 5 years. I came back, they were still here, and they were still leading in spite of all the setbacks and the challenges and the circles and the spirals, and they have continued to lead with absolute dedication and integrity. The no no big financial reward, for no honours, but just in the service of their city. So they are our biggest. I'm going to cry. They're my biggest. Yeah.
Lovely words, lovely words. And how do you think that shaped your leadership style? What would you say, like, the main areas that you really sort of highlight, focus on?
So I think at heart, my leadership style is informed by the social justice approach and it's very value based. I have learned, though, to be pragmatic. And I've learned that from many people, to be pragmatic, to work in the moment, to not push doors that are firmly shut, to look for the doors that are open for the opportunities. So in that sense, I suppose also opportunistic. Um, and humility, that there is nothing in this role or any other that anyone does on their own. So in this role, you put on a cloak of responsibility and accountability, and you have to fill out that cloak in your own way. But you are highly reliant on everyone else, and being aware of that, acknowledging that is hugely important.
Thank you for sharing. Oh, that was beautiful. Thank you. Final question. If you could give your younger self one piece of advice before going into public health, what would it be and why?
First of all, it's be yourself, accept yourself, learn to live with yourself. Know that we are all, everybody, flawed human beings. We have the best and we have the worst of everything. That's okay. That's how it is. So learning to accept that in yourself and accept that in others, and always working, of course, to be the best of yourself and to minimize the worst of yourself, but being forgiving of yourself and forgiving of others. And that will, I think, enable you to see that if you choose, and progression, as I've just said, isn't necessarily, in my view, a linear progression into a name above a door. I've just spoken to you about 3 individuals, well, a number of individuals who have lived and absolute dedicated lives of service. But if you choose to put on the cloak of situational authority, wear it lightly, yeah, and recognise that everybody who puts on that cloak of leadership and authority has got feet of clay and are the best of us and the worst of us. And don't wait to be perfect to think you want to put on that cloak, because we need the people who think, I can't do that, to step up. We really need you to do that. Yeah.
Thank you. Thank you. It has been an absolute privilege. Thank you so much. No worries, Christina. Thank you. Thank you for tuning into the Public Health Spotlight podcast, brought to you by Panoramic Associates and partnered with the ADPH. Tune in for our next episode. Take care.